Hi, everyone. Welcome. Thank you all for coming tonight. We are excited to kick off our Operation Substance Use Disorder interprofessional panel. We have some awesome people here to discuss their current roles and answer some questions that people submitted ahead of time. But first, I'm going to go around and introduce everyone. First thing is to thank our supporter, Walmart, for their financial support for Operation Substance Use Disorders. And then just wanted to introduce myself. So I am currently a P4 at the University of North Carolina. So I'm in my final year. I've been serving as the National Operation Substance Use Disorder Liaison on the Member Engagement Standing Committee. So I'm honored to be here hosting this and excited to hear everybody's experiences. So first, I'm going to introduce Bill Peppard. He is the Enterprise Pain Stewardship Coordinator and Chair of the Pharmacy Research at Froedtert and Medical College of Wisconsin and serves as an assistant professor within the Department of Surgery, Division of Trauma and Critical Care. He is board certified in pharmacotherapy and a fellow in the American College of Critical Care Medicine. During the first 16 years of his career, Dr. Peppard practiced in the surgical trauma ICU with a clinical focus on management of pain and agitation in the perioperative and trauma setting, with particular emphasis on high risk and difficult to treat populations, such as those with opioid use disorder and opioid tolerance. Since then, he's transitioned to focusing all efforts on pain stewardship at the enterprise level, which in large part includes initiatives related to oversight and coordination of opioid use disorder, as well as implementing harm reduction strategies. And Bill, you can go ahead and say welcome or hello.
Great. So, a little bit about my practice area.
Just want to introduce yourself so everybody can see you on the camera first, and then I'll go around for the other panelists.
Yep.
Okay, perfect. Next, we have Dr. Lapine. Emily Lapine is a clinical assistant professor at Binghamton University of Pharmacy and Pharmaceutical Sciences. She received her Doctor of Pharmacy degree from Albany College of Pharmacy and Health Sciences in 2016. Following graduation, she completed 2 years of postgraduate residency training at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences, Buffalo Psychiatric Center, and Dent Neurologic Institute. Dr. Lapine maintains an ambulatory care clinical practice site at Lord's Pain Care, where she inaugurated collaborative drug therapy management services. Dr. Lapine specializes in the treatment of chronic pain, substance use disorders, and psychiatric illness. Her professional research interests include non-opioid alternative therapies for chronic pain management and the integration of mental health treatment within pain management services. Dr. Lapine is an active member of APHA, currently serving as the Pain Palliative Care and Addiction SIG Immediate Pass Coordinator. She also serves as a faculty co-advisor for APHA ASP Academy of Student Pharmacists.
Hey, everybody. I'm happy to be here. Thank you for joining us.
And lastly, we have Dr. Tom Franco. So he joined the faculty at Wilkes University in 2013 with a focus in pain management and substance use disorder. While at Wilkes, Dr. Franco authored several papers on innovative education methodologies for pain management, opioid use, and pharmacist involvement with naloxone. Dr. Franco's past leadership positions include serving as the coordinator for the Pain Palliative Care and Addiction Special Interest Group, or SIG, for APHA, and the president of the Pennsylvania Pharmacists Association.
Good evening, everybody. Really happy to be here.
Great. So thank you all for introductions. Just gonna open it up for questions and discussion. So we have some questions prepared. So I'm just gonna kick it off with our first one here. So since our discussion tonight is focused on interprofessional teams, I would love to start by having you each describe what working on an interprofessional team looks like at your individual practice sites. And I'll just open it up to whoever would like to answer first.
Well, I'll go ahead and get it started. Thanks so much, Tia, for that introduction. So, the interprofessional team was fairly well established in the trauma surgical ICU before I joined there. We're very fortunate. However, after transitioning about 3 years ago to a pain stewardship role, it was a little bit less structured. And we really kind of needed to carve out our niche. And I don't think that's unique to our environment as all. I think pain stewardship is maybe about a decade behind where ID stewardship is, and we're still kind of charting our course. And we did need to cost justify the position, but it's worked out really, really well. I round on the inpatient pain service and work very closely and collaboratively with our psychiatry colleagues. And on a daily basis on our multidisciplinary pain team, it's led by a staff anesthesiologist, and we have either residents or fellows from the anesthesia or PNMR teams. We also have pharmacy learners every day of the week in the forms of PGY1s, PGY2s, and IPPs and APPs. And I physically round with the team twice a week, whereas my learners round with the team 5 days a week. And then in the afternoon, largely really collaborating with other providers. We also have an APNP on the service, and collaborating with providers to initiate quality improvement projects. So, it's been a little bit of a transition to kind of go from an established environment to an environment where you need to kind of chart your own course. But, one of the job satisfiers that I have is actually being exposed to other perspectives from other disciplines that look at opportunities and scenarios very differently with different experiences and different backgrounds. And it's really an environment very ripe for learning.
Right, I will go next and kind of introduce myself. So, as Tia mentioned, my practice site is at Lord's Pain Care, which is a ambulatory care practice setting associated with one of the local hospital systems in the Binghamton area, which is about towards the middle of New York State, all the way south. So we are right on the border between New York and Pennsylvania. So it is a more rural area. And so when I started my faculty position, the school had wanted to implement a faculty within the Lourdes hospital system. And so given my specialty area within pain and psychiatric care, we kind of worked on developing a practice site within this outpatient pain management substance use disorder clinic. So when I had started, there was not a pharmacist already in that clinic. So that was something that I helped to develop in terms of building my particular pharmacy service. So patients are now referred to me for a variety of different reasons. So it could be polypharmacy and working to deprescribe medications, could be for opioid rotations, so changing opioid therapy, initiating methadone or buprenorphine. Could also be for psychiatric care. So in our rural area, there is a lack of psychiatric services right now. The psychiatric providers within our hospital system are on a 3-month waiting list. And we know that a lot of patients with chronic pain do have comorbid psychiatric conditions. So I will be referred patients who need psychiatric care or need psychotropic medications initiated. And so I work with a team of physicians and nurse practitioners to treat patients with those disease states.
And my site is called the Wright Center it's a primary care clinic, and it's in Wilkes-Barre. So Wilkes-Barre, Pennsylvania, it's right next to Scranton. So I'm about an hour and a half south of Emily. And if you've ever seen The Office, Scranton, that's where we're at. My site is a residency program for physicians. So I have PGY 1 through 3 physicians who are there. And a large part of what we do is provide them with education on appropriate prescribing, appropriate pain assessment, how to go about engaging in evidence-based communication with patients around pain management. We do have a sizable portion of patients, much like Emily, who do have psychiatric needs. Wilkes-Barre only has, I believe right now, 2 psychiatric providers, and nobody can get in. It's just inundated with people. So we're doing a lot trying to teach about mental health first aid and other things that a primary care physician can do. In terms of substance use disorder, we do have a board-certified addiction medicine physician, and we have a nurse and a recovery specialist who are part of the team. And we're involved in terms of getting our patients not just buprenorphine, but the injectable form. We have them on IM naltrexone. But where pharmacy comes into that, first from a student perspective, our students on API rotations spend 1/2 day a week in the substance use disorder clinic. So they're able to see that as part of their experience. And where I come in to help with it is usually, and as our physician would say, I've been out of other types of medicine for a long time. Help me understand what the rest of this stuff is where I usually come on in, as well as trying to help with med access. One of the things that it's not just a local to Wilkes-Barre, it's across the country, that a lot of pharmacies won't stock a buprenorphine product for one reason or another. So it's trying to identify and have an ongoing list of where buprenorphine is available, helping people who choose methadone as their path into recovery, helping them with transportation issues. We only have 2 methadone provider or methadone clinics in our area. So it's a lot of the social things that we've gotten more involved with, more so than like the hands-on clinical things. But I think it's a great opportunity for our students to be able to see that, because you're really not given much of that in school. You're really not given much of the social side of things. And I think with social determinants of health being such a big issue right now, it's a really great opportunity for pharmacists to get involved.
Great. Thank you all for those responses. And just a follow-up question. I know, Bill, you kind of touched on this a little bit, but from each of you, has your position always been integrated into a team in these settings, or did you really have to advocate to include yourself?
I'll start with this question. So, as I had mentioned, like prior to me joining the team at my site, there was not a pharmacist there previously. So this was a new position and new to the providers within that within this ambulatory care clinic. Now, the medical director, she had previously worked in Syracuse, which is a much larger area that is north of Binghamton. And so she had worked, when she worked inpatient, had access to pharmacists on her service. And so she was one of the individuals who really advocated for having a pharmacist and knew the value of the pharmacist. However, the other providers that are at my clinic had not previously worked with a pharmacist. And so it certainly took a little more time to educate those providers on what I could do and how I could not only help them, but also help their patients and to improve outcomes, but also to take some of the responsibility off of the provider, in that they don't, they can have patients follow up with me instead of having to schedule follow-ups with them. And so that was something that certainly took a little bit of advocating. It did take some education, but it was certainly helpful that I had a medical director who was pro-pharmacy and wanted pharmacy integration. Now, because there had not been a pharmacist, there hadn't been a pharmacist there. There was no pharmacy interface in our EMR computer system. So when I started and I said, oh, I'm a pharmacist, they gave me inpatient pharmacy access, which is not what I needed, because I was not going to be working on the inpatient side. And so the IT department had to build a new interface of what this pharmacy ambulatory care position should look like, and being able to send medications directly to the pharmacy on behalf of a provider under CDTM protocol. I had to educate individuals that yes, pharmacists can write soap notes, and you know, they're like, wait a minute, you don't need access to document. And I go, no, I do. So it did certainly take some education. It probably took about a good year before I really started to build a service where I had regularly had patients on my schedule. I still am doing some advocating, still educating on things that I can do. But it certainly comes down to provider comfort, but it wasn't, it was a smooth transition, but it wasn't necessarily one that was already in place. It did take some building on my part.
I'd say a lot of the same. My site did have a pharmacist at it. It was one of our faculty members, and then that faculty member got promoted, and because of that, they transferred into a non-patient care role on campus, and there was a bit of a gap before they had somebody come back. So much like Emily, our medical director is a massive pharmacy champion, clearly knows what we can do and clearly advocates for us. And I think the most interesting part really is watching the transition in the medical residents. That has just been fascinating to me, because when they start in July, you usually see with the PGY ones, some of them are either you're their best friend, or they have this I know what I'm doing mentality. And then you see the third years who kind of just sit back and are like, yep, they'll find out, because they know how valuable that we are. And seeing some of those ones that initially maybe have been a bit standoffish start to, in time, realize how valuable you are. They're the ones that by the time they graduate are like, what, we're going to be lost when we don't have you wherever it is that we're going. So it really is, I think, in terms of how to integrate yourself, especially if there's either not been anybody or there's been a gap, it's about being strategic, pick your battles wisely, know when you need to go to the mat for something and when you need just let it go. And eventually, it's the way that it was described to me was it's a lot like the letter Y. You're connected, and then one day it just splits. And you'll be able to do kind of what you want. And I wouldn't be saying that if I didn't live it. So I think that's how I got here, and that's kind of the story.
Thank you for that. And I did want to ask Dr. Peppard, how did you kind of go about defending the financial commitment to your role, as you kind of briefly touched on earlier from the first question? I was kind of curious about that.
Yeah, no, that's a great question. Thank you. So fortunately, I wasn't the one that actually had to execute the plan, but I was peripherally involved, and we had one of our PGY2 admin residents take that on as their year-long ASHP residency project. So we allow our residents to do either a research project or a service expansion project. And the service expansion, we kind of have a recipe for that within our organization. And really, the large basis of that justification came in response to previous Joint Commission visits and regulatory standards, where we identified there were opportunities for improvement. So that revolved around not only pain management, pain stewardship, but also opioid use disorder. And once you start looking at a couple of non-compliances and looking at standardizing practice across 10 different hospitals and 40 plus clinics, it becomes clear that you actually need somebody steering the ship. And at that point, a pharmacist was more cost effective and easier to integrate and easier to hire than a physician was. So it was actually not all that difficult to cost justify, given how large our enterprise is. Again, I should have mentioned we're located in Milwaukee, Wisconsin. So we are largely the academic hospital where I practice out of primarily is about 750 beds, but we have a host of community hospitals and clinics that are in the suburban and even towing the line of rural areas as well. So it was a pretty heavy lift, and therefore it wasn't too hard to cost justify. The challenge that we're facing now is we have one person steering the ship. Maybe we need a first mate. Maybe we need to expand that team. Maybe there's opportunity to do more surveillance on a daily basis in some of those high-risk patients rather than just driving policy.
Interesting. Thank you all for those responses. I know Dr. Lepine and Dr. Franco, you touched on how your medical director was more pro-pharmacy. I'm curious what the response has been from other healthcare providers, you know, for each of you as you've gone through these roles and these positions. And I know, Dr. Franco, you talked about how the residents might be, you know, the third years, you know, might know more so about what pharmacy brings to the table. But in terms of practitioners outside of residency as well, I'm curious what the response has been to having a pharmacist on the team.
I'd say that in our OUD program, they love us. They're one of the things. So this year has been a bit of an odd year. We have a lot of interim positions on campus, so I have an interim administrative gig this year. So I've been on at my clinic significantly less. But one of the last times I was there, we were talking with our SUD team, and they didn't know about week 4 with IM naltrexone and how that can be a bit of a precarious situation for some people, and we need a little bit more psychosocial support during that time. And they just had this, how did we not know about this? And kind of that this makes things a little bit more clear type look on them. And even on our primary care side, you know, there are 3 attending physicians who are there. Plus we have specialists kind of rotating in and out. And all 3 attendings have different personalities. They have different ways of going about doing things. And you have to learn how to approach each one of them. But they've all come to appreciate and understand in their own way the value that not just that a pharmacist, but having pharmacy learners being part of the team and having them as part of the residents' learning process, how that benefits the patients, it benefits the education of the system, and it's a win for everybody. So it's been a very positive experience.
And I certainly would echo what Tom has said, in that it has been a positive experience, and that the other healthcare providers, especially at my particular clinic, have been, or, you know, are certainly now pro-pharmacy. And they each have a different approach to how they do things, and that's fine. You know, I have one provider who it still is not 100%, you know, full face hat on referring patients to me for me to see and make changes. But instead, they'd rather talk the patient through and say, I have this patient. Can you pull them up? Here's their history. Can you take a look? What do you think? Or what do you think about this plan? Or do you have any concerns with starting this medication? And so even though that she may not refer patients to me for me to, you know, to see independently, she still is utilizing my service. And at the end of the day, it doesn't matter to me as long as we're working as a team and making sure that the patient is taken care of. But then I have other providers who will send me the patient and their referral is, help me, please. And, you know, they're kind of at a loss. And so each provider is a little bit different. And I think it certainly takes time to build a rapport with each of the providers. And you're going to have you may have a different relationship with each of the providers that are there. But at the end of the day, I would say that all of the providers have been, you know, very great, and, you know, and now certainly take advantage of what pharmacy has to offer. And I have not often, but I have had some primary care providers even reach out with questions on patients. And so that has been, that's been positive as well.
That's interesting to hear. I know just through my AbbVie experience, in all types of settings, you might get providers very pro or very not pro pharmacy. So I've seen it all just in my experiences. But I think just from the range of patient populations that you three see, I'm curious kind of what the patient response is to seeing a pharmacist as their main provider in regards to opioid substance use disorders, or just having a pharmacist on the team. Yeah, so if you guys could just elaborate on that, I think that would be helpful.
Yeah, so I think my experience might be a little bit different from my colleagues on the call, because I'm really primarily focused on the inpatient setting when I'm face-to-face with a patient. Certainly I help drive policy, and I collaborate with behavioral health and in primary care to offer these services in an ambulatory environment, but I'm not actually face-to-face with those patients. So when I do see patients as part of the multidisciplinary team, they are usually experiencing acute pain on top of their opioid use disorder, which may or may not be managed by medication, right? So we've got folks on the trauma service that come in and are a 2 gram a day heroin user and have a trauma, and they have acute pain on top of it, and it's really complicated. And I would say that the response is actually overwhelmingly positive. For whatever reason, we seem to be a little bit more approachable, maybe a little bit less intimidating compared to a provider. And I feel like when we talk to them and ask them about their history and try to explain to them what our approach is to managing pain, and then let's figure out something about this opioid use disorder before hospital discharge, we offer a perspective that is focused on that issue in particular. And it's a very non-judgmental mechanism of communication, and it's generally very well received. They have the sense that we understand, that we can connect, that we relate, and that we're thinking on multiple levels, and really, creating and maintaining that covenantal relationship with the patient is so important, and gaining that trust. And you can do that in tandem with the team. You can do it in a way that complements the other interactions they have with the team, but overwhelmingly, it's very positive. And my perspective might be a bit biased, because most of the patients that I'm seeing are truly in really uncomfortable acute pain, and they tend to be in general more receptive to recommendations at that point anyways. But I will also say that when we are able to get patients induced on buprenorphine in the inpatient setting, we have outcome data that says the rate at which they leave against medical advice because they're in pain, or they're in withdrawal, or they're not trusting, has gone down dramatically. And the 30-day readmission rate has gone down dramatically when we're able to induce these patients after we manage the acute pain, but before the discharge. It's been a very successful process. And again, they're very receptive to it, especially when it's kind of a 1-2 punch in combination with psychiatry maybe whispering in their other ear, and pharmacy is whispering in one ear. It's a good approach, and it's been a great experience to actually make those meaningful interventions on a patient-by-patient basis.
I think at my clinics, we kind of get a mixed bag. A lot of the patients at my clinic, I should say, we do serve a socioeconomically disadvantaged population in my clinic. A lot of times patients either aren't or haven't gone to see anybody in the medical institution in a long time. Most prescriptions are mail order. Things are kind of just sent to them. So usually the first time that they'll see me, if it's the very first time, their answer is, "Oh, there's a pharmacy in the building. Can I get my prescriptions filled there?" And it's like, not that kind of pharmacy. But once they start talking, and once I let them know, like, "Hey, here's why I'm here. Here's what we're going to do. We're going to talk about your meds. We're going to make sure that your med list is right. We're going to go over how to use everything, what you can expect from it." They become very receptive. I've had patients come in and say, I knew I was good. Like the people who know me, they're like, I knew you were going to be here, so I brought this. And they hold up like the big Ziploc bag full of all of their pill bottles. And they're just like, I don't know what to do with this. What do I do? Help me. So you do start seeing patients realize the value that you bring. And that's, when I have API students, I'm the one kind of running things for about the first week. Then I hand the reins off and off they go. And the response is the same, even when a learner is the one who's in there. Before I came to Wilkes, my first job was in a pain clinic at a local regional medical center. And I think that when you talk about pharmacists getting involved with all this and what patients say, the best thing I ever heard was I was there for about a year at the time, and they go into the front desk. I was embedded in a pain management clinic. So people are coming in for their injections in their back and their neck and all that. And the standard line at the front desk was, and what physician are you here to see today? And the patient said, no, I'm here to see my pharmacist today. And I was like, that's when you know you've made it. That's great. So I think that with building enough trust and enough rapport with patients, because you will see these folks on an outpatient level frequently, you really do start to feel that trustworthiness and that bond that people talk about when it comes to the pharmacist patient relationship. You really feel that a lot in community practice, and obviously so, but in all these other practice settings, the more touch points you have with that patient, the more and more you're going to be able to build it and get that same level of response.
One of the first times I was seeing patients, this was probably within the first month or so, the front office staff receptionist came back to tell me that my patient was going to be late. I said, okay, no problem. And they tell me the patient is at the pharmacy. So the patient did, there was some disconnect that the patient was going to be seeing a pharmacist at their provider's office. And so instead, they show up at their pharmacy, and the pharmacy calls and says, why is this person here? They say they have an appointment with a pharmacist, and I have no idea what they're talking about. So it also took some educating of our receptionist staff on, informing the patient that the pharmacist is here in our facility, kind of a brief, maybe one-line sentence of what I do to kind of help the patient understand what they are going to be seeing me for. And a lot of times the patients don't know why they're seeing me. They're like, why am I here? Why am I seeing you? Like, why, there's no pharmacy here. You dispense pills. And so there was some misconception on the patient side, but what Bill had mentioned about patients, perceiving pharmacists as being, maybe more approachable. One of the things that I have found is that patients have had a very positive experience. Part of me thinks that it has to do with that I have more time. So if we think about our other providers, at least in my practice, they have a certain number of patients that they need to see per day, per week. And so their appointments may be 15 or 20 minutes. Whereas like my appointments are at least 30 minutes. And if it's a patient I haven't seen before, I usually prefer to see them for 45 minutes because I want to do a thorough medication reconciliation. And so that is one thing that I have found that even just makes the smallest difference, and that medications don't get discontinued. Medications just stay on the patient's med list, and we think they're taking them, but they're actually not. And that makes a big difference, because if we think a patient is taking something, we may plan or we may create a treatment plan around that when in fact they're not taking that, or they're having a side effect of something, or they're not taking it 3 times a day, they're only taking it once a day, or vice versa. So, what I have found is that patients have been very receptive to seeing me, but I do think it has to do with, I just have more time to sit, to listen. Pain is a very subjective, it's a debilitating condition. And so when we're trying to rush patients in and out and say, here's the plan, see you in 3 weeks or see you in 3 months, sometimes the patients may feel that they weren't necessarily heard. And that's at no fault of any other provider. It's just that in our healthcare system, we do have to meet quotas, just like a community pharmacy would, right? There's certain metrics that you need to meet. And so I have found that just by listening to the patient or taking the time to educate them on why I'm doing something or why this is the plan or why we want to make this medication change versus just saying, well, this is the change, here you go, has certainly been very positive.
Great, thank you for that. And I think that brings me to the next question that somebody submitted prior to this about, do you, I guess, in your different roles, do you believe that social workers and pharmacists should work together in terms of looking at a patient individually and offering resources and connecting them with community resources or contacts?
Yeah, I mean, that's definitely true in our environment, and I think Dr. Franco touched on this a little bit earlier, is that those transitions of care and those social elements are super important. We were able to cost justify a social worker that exclusively worked with our psychiatry group to manage transitions of care of opioid use disorder. And it took over 9 months of searching to find a candidate. And we offered the job to 3 different people, and we got ghosted twice because the market was just so tight and the pay wasn't maybe as attractive as it should be. But we have an extremely close working relationship with our social workers when we induce patients in the inpatient setting. I think one of the biggest challenges that we've faced is many of our patients need to go to some sort of facility rather than home upon discharge. And, there are a lot of organizations and a lot of facilities that will just outright refuse patients that are on buprenorphine. Now, legally speaking, they can't do that, but it happens routinely, and you have to fight that battle on an individual case-by-case basis. There's plenty of articles published out there looking at, legislative interpretation and different facilities that have been brought to suit. But the reality is that it's really challenging to sometimes place these patients. And even if they do go home, there are lots of barriers. So we actually promote our students and our residents to get to know our social workers, to understand some of these complexities. I think, again, Dr. Franco touched on this earlier, that you learn what to do in school on how to manage medications, but when you have to apply it to a practical situation, to a real person, going out back into the community, there are countless barriers that you have to work through. You can't just prescribe a medication and walk away. A medication is only effective if it's filled and it's taken, and all the other social elements are in place for that patient to succeed.
Yeah, that's really interesting. I know just from my API experiences, I have not ever directly worked with social work. I think that those departments seem pretty separated in a lot of healthcare settings that I've been in. So that is pretty interesting that your team integrated something like that. Not sure if anybody else wants to comment, but there's a question in the chat, and then I think I just kind of wanted to open it up to anybody that wanted to unmute. We have other questions prepared, if anything. But there was a question in the chat that I wanted to read off from Diane Ash. Do you believe that there will be a significant change in the prescribing and stocking of Suboxone once the XDEA number rule change begins and give patients more access to Suboxone? Are you concerned about the effect it will have on substance use disorder clinics and pain management clinics?
This is a great question. And I'll make sure that Tom comments as well. Here's what I'm suspecting. And, I'm really only talking about kind of like what I see as and that's my basis for my thoughts, but in theory, it's really great that in removing the X waiver, you would think would increase access. But if providers wanted to prescribe Suboxone, they would. They would have gotten the XDEA. So the fact that the removal of the XDEA is fantastic, I still don't think providers are going to be prescribing more Suboxone. So we have 4 prescribing providers in our clinic. 2 of them do have the XDEA, 2 do not. One plans to, of the 2 who don't, one plans to start prescribing Suboxone, one does not. So that's 50% of providers, at least in my one clinic of a population of 4. But if they wanted to prescribe Suboxone, they would have already been doing it. So I don't actually think it's going to create more access. The other problem that I have in New York State is that there have been laws enacted about what you can prescribe, how much you can prescribe. There are concerns about how much opioids patients can, or pharmacists can order and stock in pharmacies. And we can't, just the removal of the XDEA is not going to change New York State law with the blink of an eye, right? And, you know, that's a whole nother story about why those laws exist. But that's my suspicion. Tom, I know that you started to unmute and I want you to share your perspective.
Well, we're in on the same conversations, Emily. So it's the same exact thing. People who wanted to prescribe buprenorphine would have been doing it. We know that the fear of regulatory oversight is real. Physicians and other prescribers are afraid that DEA is going to come after them. The pharmacies are afraid that the wholesalers are going to cut them off. You know, this is putting on my PPA hat. You know, this is a discussion that we have at the board table routinely, is like, what are we going to do when this comes out? The 2 biggest questions we had is, what's going to happen if more people start prescribing it, which, again, I agree with you, Emily. I don't think that's going to happen. What are the pharmacies going to do? Because some of these pharmacies, if you're an independent, you're on a razor thin budget, and you can't afford the court costs of the DEA hauling you into federal court. And 2, because the part of that act that was passed said that there has to be a one-off 8-hour training. Well, who's going to be policing that 8-hour training? Is that going to be the pharmacist that has to do it? And if the pharmacist is going to do it, how much time is that going to take? Are we going to get paid for it? So those are all questions that still exist. Taking that all out of the picture, I think it's easy to look at this and say, you know, it's great, but is it going to do anything? And if there's one thing pharmacists are really good at doing, it's filling in the gaps. Because look what we did with COVID. This country was vaccinated because of pharmacists. So I think that there's ample opportunity for us to get involved with this. If your state has collaborative practice agreements in place, or if you work for a hospital system that has that, we already have pharmacists, you know, who are doing pain management work outpatient, who are pursuing, like Emily, you're involved with a lot of this work, and Bill, you're involved with this work on the inpatient level. That I think there's a tremendous opportunity for pharmacists, if we advocate for it, to be able to prescribe and manage buprenorphine now that the X waiver is gone. I think that we have every opportunity. It's a Schedule 3, so we have every opportunity to do it. That's more access to care for patients. That's probably improved care because it's a medication. We're the medication experts. And it's more job opportunities for pharmacists. So I think that there's a win out there. We just need to be willing to go and get it. And I think we have the ambition and the motivation to do it.
From the inpatient perspective, I share that view as well. You know, we've gone to the medical directors of different disciplines trying to feel out what sort of appetite there is to hardwire buprenorphine training into our residency program. We share campus with the medical school. And, you know, internal medicine, primary care, I would say is lukewarm. We've got emergency medicine that is 100% on board and they want to hardwire it. Psychiatry and behavioral health already has it hardwired. Infectious disease is interested. We have some providers that were wavered and we see opportunity for growth there. But the common denominator that we keep coming back to is pharmacists, CPAs. Pharmacists, CPAs in the ambulatory clinic. We have over 30 pharmacists in our ambulatory clinics now with dozens of CPAs on the books. It would be very easy to operationalize at an organization our size. One of the challenges is actually hiring pharmacists that have expertise or interest in doing this. And I think that's the step that we're at right now, is trying to feel out what does the applicant pool look like. We've got residents graduating in June that are still looking for jobs, and that's the next step that we're looking at.
And it's interesting that you brought up the interest part, because one of the things that AACP did about 3 years ago now was updated their learning outcomes. Now, I mean, it's not ACPE level outcome, but recommended learning outcomes for student pharmacists around substance use disorder. So more robust education on buprenorphine, on the social issues, on the legal and ethical issues, on how to manage it, on how to approach it, on the business end of it. All of that now is being pumped as this is something we want our graduates across the country to be able to have. So if you're interested in that document, it's the 2020 SAPER, SAPER document from AACP. You can see every learning outcome that ideally, when the next set of standards come out, that will be somehow incorporated into that, or even incorporated into NAPLEX. These are things that we're really hoping we start to see because of something like that.
Wow, very cool. And I think that also brings to the next question from Evan Johnson in the chat. How can we as providers help to reduce the stigma around buprenorphine and patients on long-term opioid therapy? I know just in classes, when we talk about it more, it helps us learn about that patient population and approach it in a way that has less stigma inherently. But I'm curious, what strategies you guys have taken, and what students can do, what other providers can do to help reduce that stigma.
I'd say one of the things is talk about it. Talk about Suboxone, talk about buprenorphine, talk about opioid use disorder. Don't be afraid to use those words. They're not dirty words. They're not top secret words. The more we can talk about it, the more we can educate others and in ourselves, really, any provider, the better we may be at being able to reduce stigma. But I feel like if things aren't talked about, it just further potentiates the stigma. But being able to know what resources are out there, share resources, don't be afraid to talk about the resources or ask questions, certainly will help to kind of break down some of those stigmas.
Yeah, I'd say leverage your presence on social media. As an aging millennial, my knowledge of things like TikTok is kind of not the best, but I know that that's a great opportunity to help spread good information that's out there. And also, I think something you could do in your communities right now, partner with your first responders. They really want to know about SUD. They want to know about naloxone. They want to know what happens if I get fentanyl on my hands. They want to know these things because there's a ton of misinformation about all of that out there. And we recently did a partnership with our fire department. They are the #1 purveyor of naloxone in our part of the state easily. I don't think there's a fire department throughout Pennsylvania that does what these guys are doing. We partnered with them. We did a little educational thing just on that. What do you do if you get fentanyl on your hands? We had 2 different TV media, 3 different print media show up. It's on Twitter. Like, those are the things that you do. And just don't read the comment section, because you know what goes in comment sections. But I'd say use the platform that you have. And Emily, you said it the best. Like, don't be afraid to talk about it. Like when naloxone goes OTC probably over the summer, there's probably going to be a large amount of public pushing via the comment section on social media about why is this here? How come insulin's not over the counter? How come these people get this type of treatment, but kids with cancer can't? This isn't fair. This is wrong, and all of that. And we need to realize that somewhere deep inside, people feel that that their feelings are valid, and you need to validate them to at least reach them. But provide them with good information. Provide the public with good information, and provide your preceptors with good information, because this is one of those all hands on deck situations. There's stigma in our own house too. So helping to educate your preceptors is a great thing you can do, whether you're on IPI or API coming up, especially as this comes out over the counter.
Awesome, that's great. And another question in the chat from Marissa McGinnis, and I also have had some direct messages for questions related to getting involved in organizations. But Marissa's question is, what type of residency program do you suggest she goes for? She's currently a P2 with the future career goal of working with patients who struggle with substance use disorder. And, you know, what type of residency program should she be looking for? And then as a student, what type of internships or organizations do you recommend getting involved with?
This is a good question. And I honestly don't think it matters. And I say that, and I'm like, those maybe aren't the best words, but you can get involved in this type of practice doing a PGY2 in pain palliative care, doing a PGY2 in psychiatry, like I did, doing a PGY2 in ambulatory care, which is basically just your outpatient AM care. You see a little bit of everything. I also know people in the pain world and SUD world who did PGY2s in hematology oncology, because we know that patients with cancer need pain treatment. So I don't necessarily have one good answer saying, oh, you need to do a PGY2 in this area in order to do this as your career. I think you can get involved in this area through a number of different ways, through a number of different channels. And certainly your residency experiences are also going to be what you make of them. So, you know, when you're looking, you know, you should first start by thinking about PGY1 and making sure that the PGY1 programs you're looking at have rotations in these areas. So maybe you want to work, you know, you want to look to see if there's a rotation in ambulatory care. Is there a rotation in neuropsych? Is there a rotation in pain? And that may help you get a better idea of where you might want to go for PGY2 and what type of specialty you might want to look at. But ultimately, you can be involved in treating patients with substance use disorder through any of these channels.
Yeah, completely agree. You know, a lot of the folks that I know who are involved in this area of work, they did 0 to 2 years of residency. Some of those, I'd say the majority of those residencies were not pain management. Some of them were just like one of the folks that I know, amazing work, 1 year of residency, and it was like the general PGY1 go with it. And there's not a person who I don't think knows who this gentleman is down in Texas. I think everybody might know who he is, but Emily's right. It really is what you make of it. One of the things that I tell every student is you should never feel pressured to do a residency. You don't need to do a residency or a fellowship or any postgraduate thing to be happy or to be successful in your life. And that's the most important thing, is that you find happiness in whatever it is that you do. If residency is in your heart and you know that that's where you need to go, as a P2, your preparation starts now. That's when it starts. It's strategically positioning the pieces such that next year you can execute and really stand out on paper. Because to put it bluntly, when you go to get that residency, what makes you so special? That's what you have to try to answer on paper. So trying to come up with some great things to do now, whether that's internships, research projects, a lot of service, leadership, to eventually get your foot in the door to sell it on an interview. That's where it really starts. The most important thing is you got to follow your heart. This is one of those the universe unfolds as it should type things. where you're meant to go, you'll go. And no matter what path you take, if this is the kind of work that you really want to do, you'll find a way to get there, no matter what path you take.
Yeah, I also want to echo that and then emphasize that as a student, it's kind of hard to really decide what appies you might be getting or pick and choose those experiences, but there's a lot of room to get involved with Operation Substance Use Disorders through APHA. You can do things on a local level or a national level, which I'll have a shameless plug for our Institute conference coming up, but there are a lot of things in terms of organizations just taking that extra step and making sure that you consistently, pursue things that you're interested in or make time for them. I think that really goes a long way in terms of your confidence in the area that you want to go into, and then also just how well-rounded you are in terms of residency applications or fellowship applications. Yes, and so Elise just dropped a link to the Institute page. I'm gonna go ahead and pull up the slide here. So Institute on Substance Use Disorders is happening May 31st through June 3rd. Registration does close pretty soon, May 8th. I never had the opportunity to actually go to this, but I've heard absolutely wonderful things. And I know as a P1, I was like inspired by the older students that had gone to it. And unfortunately, COVID hit and things went virtual for a little bit, but now we are back in person. So highly encourage you all to look into attending this if possible. And I know down in the chat, Diane dropped another question related to the DEA practices that are changing. So she said she recently went to a DEA medication opioid use disorder summit, and they were discussing removing the limitation flagging pharmacies through a statute. And do you think that this would be successful? And then they also discussed the training program, when that would be done. And the DEA said probably at license renewal. The speaker from the DEA said that. And then do you support this option?
I think that there have been attempts to try to unwind the clock from what happened as pretty much a ramification of the 2016 CDC guidelines. The 2016 guidelines, and Emily alluded to this earlier, really did kind of put the pedal to the metal on a lot of states to institute legislation and a lot of companies to institute policies that were really rough on a lot of folks. Some places are starting to try to unwind that, but the political capital for something like that, it's just not there right now. So the DEA can certainly say, hey, we're going to back off on this. But what the DEA isn't controlling is the wholesaler. So the wholesaler may still feel pressured, or they may still have some arbitrary number of product that they'll send to a given pharmacy and afterwards say, nope, you've reached your quota for the month. So I'm all for things that we can do to improve access to care. Hopefully we've learned as a system and as a society where the mistakes were back in the 90s and early 2000s with overprescribing. But if you look at a lot of the folks now who are unfortunately suffering with an addiction, the primary age of people that are dying, it's like 40 and under. So they weren't impacted in the 90s or early 2000s by the overprescribing. They were either not born or they were like 7. So it's not necessarily all about prescription opioids. I think there's a lot of untreated mental health that is unfortunately going on. And you look at the incident rates of depression, anxiety, ADHD since COVID, and they're all through the roof. And as we've been saying, there's not a lot of psychiatric care, and there's still a stigma around psychiatric care. So I think that, opening up more avenues for people to get help and for people to get treatment is great. If the DEA wants to back off on going after pharmacies, awesome. Let's have them continue to advocate to open up more opportunities for other things as well. And instead of being an enforcement, let's have it be the Drug Enforcement and Advocacy instead of the Drug Enforcement Agency would be a great thing to do. And as far as the education on license renewal, okay, I mean, that's That's fine. I think any 8-hour training will do. I think people can even retroactively use the data waiver to check the box that they did it. It's just more of who is ultimately responsible for ensuring the box has been checked. Is that the pharmacy? Is that the State Board of Medicine? Is that the insurer? I don't know the answer to that yet. So more on that to come. But as far as that education part goes, cool. I do find it interesting that not one pharmacy group has been accredited as or listed on SAMHSA's website as a group that can provide that training. So I think APHA is looking into it. Keep going. We can totally do this.
Thank you. Yeah, and I know we're at time right now. It's 9:31, so we won't answer any more questions. Elise, I believe that this recording will be posted somewhere, correct?
Yep, so this recording will be made available within a week on the Operation Substance Use Disorder page. And if you're interested in looking at any of our past webinars that we've had, there's 5 others that have been in this series. So those are on that website as well that you can check them out, but this one will be made available in the next week or so.
Awesome, thank you. Thank you from all of the panelists. We really appreciate your insight. And I hope that this inspires people to really take this back to their schools, to their practice settings, or IPPEs, APPEs, whatever it is. So thank you all for your time.